Now we all talk about, is CT perfusion better or is MR mismatch concept better? So I thought it would be interesting if I just showed you the slide. We have both in our hospital. It depends on what I use. If I have less time, patient's renal functions are all right, I may do a CT perfusion. If I have a little more time, I do an MRI perfusion. Quantitative CT perfusion mismatch classification using cerebral blood flow and Tmax is similar to perfusion-diffusion mismatch. The greater accessibility of CT perfusion may facilitate generalizability of mismatch selection in patient selection and trials. So it is more the convenience which you have, but I don't know how many have that rapid software in the CT to use this. Now then came the era of a series of thrombectomy trials. If you look up the New England Journal of Medicine from, I say, March, January, February to April, they were full of Mr. Clean and Reverse and Escape and Shift Prime and Extend and Down. And if you see the absolute benefit that the percentage increase in MRS, 0 to 2 and 90 days, kept on increasing as we became more and more intelligent with these slides. Now this is just to show you CT, CT angio, perfusion, preoperative, endovascular thrombectomy, and postoperative DSA. Then came the very famous diffuse trial, which was in the Annals of Neurology in 2006. That trial was undertaken to determine whether the MRI profile can help to predict clinical response to patients with ischemic stroke treated with IVTP 3 to 6 hours after the onset. And the key results of diffuse were target mislight pattern was associated with a substantial benefit of reperfusion to 67%. Malignant MRI pattern was associated with high risk of fatal symptomatic intracerebral hemorrhage. Small DW, PW lesions are associated with favorable outcomes. So that was the extended age. So then came the very famous, which I think is a extremely nice trial according to me. I must have read it a couple of times. This was the MI-guided thrombolysis of stroke with the time of onset. I know it's very common, at least in the Apollo Hospital, must be common in any hospital, that a patient lands up, इनको लकवा हो गया जी, कितने बजे हो गया पता नहीं, सोए थे, उठे लकवा था. Now what do? Do you send him home? Do you try to find out how can I help this guy? So this is where this trial called the wake-up trial, it came. And you know, the wake-up trial was very simple. They took only 2 MRI criteria. MRI in patients with stroke, with the known time of symptom onset was the present, identified by presence of a visible ischemic lesion on diffusion-weighted images, combined with the absence of a clearly visible hyperintensity signal in the same region on flare, which would mean this stroke is less than 4.5 hours. So just by doing 2 images, you have got the answer of a wake-up stroke, that this wake-up stroke is probably less than 4.5, which is the easiest thing to do. A very nice study to prove the efficacy and safety of MRI-based thrombolysis in patients of unknown time onset. Multicentric, randomized, placebo-controlled trial with etiplase versus placebo 1:1. Planned sample, 800 ischemic stroke patient. They had no funds, so they took only 503, equal number between the etiplase group and the placebo group. And the inclusion criteria, of course, standard exclusion, and this was the primary endpoint, which you could very well see for yourself. The modified Rankin at 90 days was much better in the etiplase group than it was in the placebo. So what was the conclusion of this trial that is called the wake-up trial? In patients who have unknown onset of stroke with symptoms, MRI pattern or DW flare mismatch with ATP resulted in better functional outcome than placebo. Consistent benefits all categories of outcome and major clinical endpoints, right? Numerically, higher rates of ICH and tend towards mortality with AT plays, yes, which might have become significant with larger sample size. Yeah, there were higher chances of interstitial hemorrhage, but I think taking that into consideration, also we would take that the wake-up trial was a positive trial. Then came the Extend 2019, and which I had the good fortune of hearing the gentleman who did this trial. His name is Henry Marv, and what a fantastic presentation it was. And let us see what he found from 4.5 hours to imaging in these patients. In patients with acute ischemic strokes with salvageable brain tissue and etiplace compared with placebo, 4.5 to 9 hours post-stroke improved functional outcome at 90 days. They took away patients who had large artery occlusion, who required a thrombectomy, could have been taken. This was 225 patients from 17 centers in Australia, Taiwan, Finland, 2010 to 2018. All 220 of the planned 310 patients have been enrolled. The trial was terminated, not because of anything else, because the logos equipos after the publication of the positive result of the wake-up trial. Excellent baseline function, hyperperfused but salvageable brain tissue detected in the automatic CT MRI imaging where they had got the result. Exclusion was very simple. A trial of 113 patients randomly assigned to a place equal number. The primary outcome occurred in 40 patients in the etiplace group and 33 in the placebo group, which was p-value was significant. And this is just to show you the graphic, which is obviously very clear on the modified Rankin scale. Symptomatic intracerebral hemorrhage occurs in 7, 1 in 80 plays. A secondary alternate analysis of the distribution of scores of the modified Rankin did show a significant improvement in group difference in the functional improvement at 90 days. So the Extend trial, the conclusions of this Extend trial were, among the patients in this trial who had ischemic stroke and salvageable brain tissue, the use of AT plays between 4.5 and 9 of stroke onset, or at the time patient woke up with stroke symptoms, resulted in a higher percent of patients with minor or no neurological deficit. Interestingly, if they had a patient who slept at 10 o'clock, woke up at 5 o'clock, they presumed that the stroke occurred in between this period, and if he was in the 9 hours period, he was recruited in this trial. There was more cases of symptomatic intracerebral hemorrhage in the etiplace group than in the placebo group. So this was a large meta-analysis from Lancet. Recommend everybody to read. And this is they had extending the thrombolysis from 4 to 5 hours, wake-up stroke using perfusion imaging, a systemic review on meta-analysis of all the 3 trials. Extend ECAS4 and EPITHED was done by this group, and this was Extend, ECAS4 Extend, and EPITHED. He had analyzed all these 3 trials to find out that, and the meta-analysis showed that patients from 4 to 5 hours from stroke onset of wake-up with a salvageable brain tissue who were treated with etiplace achieved better functional outcome than patients given placebo. The rate of symptomatic intracerebral hemorrhage was higher in the etiplace group, but this increase did not negate the overall benefit of thrombolysis. So, ladies and gentlemen, I don't know if I've been able to send my message through to you that I have nothing against neurointerventions. It should be called the Department of Stroke and Neurointervention, not Department of Neurointervention and Stroke. Stroke is a clinical diagnosis. Stroke has to be seen by a neurologist. A stroke has to be studied by a neurologist. Stroke has to see what are the perfusion, diffusion. And then you have to consider whether you require any intervention. And what percentage of people require intervention is not very high, at least in our own experience in our own hospital. So ladies and gentlemen, please take away these messages for you from this hall. Perfusion images in acute ischemic stroke is a promising technique. Recent trials show that ischemic stroke 4.5 to 9 hours after stroke or wake-up stroke with salvageable brain tissue would benefit from IV TPA. In the modern era, AIS managing the IV TPA still remains an essential measure. I again repeat, an essential measure before intervention stroke management is done. When I went to Milan this time for the European Stroke Conference, series of paper on mechanical thrombectomy. Some people were giving TPA before, some people were not giving TPA before. So I remember, I and Dinesh were there, I asked, what is the recommendation would you do? You have a patient who has a stroke. Would you give TPA and then wait for the LOA to be seen? Or you would still go for a thrombectomy? The answer is still not known, which still means that in the modern era of stroke management, TPA remains an essential measure for consideration, and interventional stroke management is also there, but remains a side tool for the management of acute ischemic stroke. Ladies and gentlemen, you cannot function alone. You have to function as a team. And I've been fortunate that in the Apollo Hospital and with the full support of the Apollo management, that I've been able to set up an excellent stroke unit. And most of the guys you see here are sitting in this gathering here. Again, Dinesh has said, please, please, please subscribe for Stroke Neurology, P N Renjen. You will see wonderful videos on that. Read them, follow them, and read more and more on that. So, ladies and gentlemen, this is the beautiful hospital where I work, and thank you very much for a patient hearing.